Hello, everyone. Welcome, welcome. We're going to give it about a minute or so just to let everyone hop on before we get started. Hello, everyone, and welcome to the first webinar of the year hosted by Critical Path Institute's Rare and Orphan Disease Programs. My name is Dominique Cruz, and I'm a project manager for the Rare Disease Cures Accelerator Data and Analytics Platform, or RDCA-DAP. RDCA-DAP provides a centralized and standardized infrastructure to support and accelerate rare disease characterization with the goal of accelerating therapy development for rare diseases. It's my pleasure to welcome everyone to today's webinar in partnership with CPAT's Quantitative Medicine Program, Understanding Disease Progression Models. What are they, why are they useful, and how are they applied in rare and orphan diseases? A high-level overview. Before we begin, I'm going to start with a few housekeeping items. If you have any questions throughout the presentation for our speaker or the panelists, please put them in the Q&A chat box. The chat function is disabled for everyone, just so we can make sure that we aren't missing any questions that pop up. And all participant lines are muted so that we can reduce background noise. This presentation is being recorded and will be made available on the CPAth YouTube channel. Now I am pleased to present our presenter for today. Dr. Luke Kosinski is a scientific director in the Quantitative Medicine Program. Dr. Kosinski has primarily worked with the Transplant Therapeutics Consortium, leading efforts in regulatory endorsements, as well as with the Huntington's Disease Consortium, developing disease progression and patient dropout models. I'm excited to hand it over to Dr. Kosinski now, who will take it away from here.
Thank you so much. Let me share my screen. Let's see. All right. Let me know if you all can't see that, but I think it should be fine. And if I keep looking off to the side, it's because I've got multiple screens. So, okay, let's get going. So just a bit of context here. So I want to explain that, I'll be presenting this how should I put this? Mostly from my own perspective on disease progression modeling. I think if you were to look in literature or ask other people, you might get a little bit different thoughts. But I'm going to be talking a lot about, I guess, my own experience and ways that I think is helpful for thinking about disease progression models, at least at a high level, and understanding, what they are, why they're useful, and how we apply them. I do want to give a context because I'm trying to stay pretty high level. I'm not going to get much into details and much into like mathematical equations. I'll have equations on, I think, one slide, but it's mostly going to stay pretty high level. And yeah, I'll be drawing on a lot of examples from my own experience. Okay, so let's keep going. So what is a disease progression model? For the basics, I've drawn from the literature a bit here. So this first quote is from Nick Hulford from a paper from 2015. And I've paraphrased a bit here. But the basic idea is disease progression models explain the trajectory of the disease. So kind of like the natural course of the history, like how is this disease severity changing over time using repeated measures of disease status. So this is something that's telling us, or at least we're using to estimate how severe the disease is. So the example I have here is the MDS-UPDRS. So this is the Unified Parkinson's Disease Rating Scale. And this is often used as an endpoint. In other words, kind of one of these ways we're figuring out how severe is the disease. And this is tracked over time. You can kind of see that. Let me see if I can get a laser pointer here. You can kind of see that going over time. So you've got the endpoint over time in months. And we look at this not just in a total population, but in different patient populations. So one of the things about these models is we can actually include different patient characteristics and get an estimate, not just of what the overall trajectory looks like, but if you have a certain patient population, what does that look like? So if you have like an age cutoff or something along those lines, you can kind of see, you can get a sense of how that looks in each population. And then I also have another quote here from Jeff Barrett and co-authors from 2022, where he said that disease progression models integrate mathematical functions and underlying scientific pathophysiologic principles to quantitatively describe the course of disease progression. So if we think about that, it's not just that we have a mathematical function that's related to disease progression, we're also trying to incorporate kind of the underlying biology. What do we know about the disease? What do we know clinically? What do we know biologically? And how do we capture that quantitatively in a model? Okay. And one other thing to note, just to keep in mind as we go through this, what I'll be showing you throughout the talk is a number of figures that look like this one on the bottom here. This is something which is, it's from what we call a clinical trial simulator tool. I'm not going to go into very many details about that. That's a really important topic that deserves its own webinar. But the basic idea here is that we've used a model to kind of simulate what this disease trajectory looks like in different groups or populations. In this case, we have a group which is taking a drug, which we've got some hypothetical drug effect and a control. And I'll be showing you plots that look like this that come from simulations that are based off of these disease progression models. Okay, so what goes into a disease progression model? I think the most obvious thing is that we take clinical trial and observational study data, which has got those repeated measures over time, and use that in the model. And the example I have here is from an electronic health record, which was taken from Wikipedia. The important thing here to note is that these clinical trial and observational study data, they're capturing different patient characteristics and features, which we can use to track over time. And then we can combine that with some sort of statistical model that captures change in an endpoint while accounting for these different patient characteristics. So I said there'd be one slide with equations. I have a very, very basic equation here. So if we think about what's a statistical model, I think, there's different ways we could define this. What I want to think about today for this talk is just, we're thinking about it as a representation of some kind of system with a random component. And the random part is really important because this is really kind of the error. We can think of this model as, this is just a very simple example of a model where we have some variable y, some variable x, and x is kind of predicting y, and we have a bunch of points. And we fit this straight line, which has some intercept and some slope through these points. And this is the really important point here, is that there's a little bit of error in this. These points don't exactly match up with the line. And when we're fitting this and trying to understand it, we're trying to pick a model that has the least amount of error. So we want to reduce this term, get the model that fits the data as best as possible. And obviously, depending on your data, you could have a data that's got a lot of variation in it. There may be a certain amount of error that you expect to see at the end. This is a model with relatively little error. And let's get a little more specific here. So this is a pretty vague example. I want to think, though, about how we actually combine these the patient characteristics with these sort of statistical models. So if we see, let's switch to a pen here. So let's think about this in terms of, let's say, Huntington's disease. So instead of Y, we'd have some kind of endpoint for Huntington's. Let's say there's one endpoint which is called total motor score, so TMS. And this would be something that would be tracked over time. So rather than this X, we'd have time T. And when we think of this equation, we can actually make it, this is a very simple thing where we have TMS over time, but we can also add in those patient characteristics. So Huntington's disease is a disease that's genetic. It's dependent on the number of CAG repeats in the Huntington gene, and it's something that progresses over a patient's entire lifetime. So we'd imagine, and we know this, that a patient who is older has had more time for that disease to progress. So we might represent this in model form, where rather than this equation here, we might have, let's write this out. Apologies for my writing this out with a mouse, because it's a little bit hard to read. But we might have TMS equals, we have some kind of population intercept, but then we might also have the age of a patient affecting the intercept, right? And then we still have our beta B1. And then this is going to be time. and then some error term. And then I just want to, and the only reason I'm showing this is I want to think about, what happens when we actually add on age. Well, if you have someone with advanced age, we might think of this as just shifting this line upward. So rather than the line being down here, now it's shifted up over to here. And we can also add on other things like the number of CAG repeats would affect the slope. So that would actually kind of be added to this term over here. And we'd actually have like faster slope or slower slope, depending on the number of CAG repeats we see. So again, this is, just a really quick rundown, but the basic idea here is that we take these statistical models and we can add on different patient characteristics, and that will tell us what kind of different populations look like in their trajectory who have that particular age, for example, or a different number of CAG repeats, or whatever characteristic you're thinking of from whichever disease you're looking at. And then these get even more complicated. So what I'm not going to show you in terms of equations is something called random effects, but this is really important to think about. So if we're looking at different patient populations, one thing we can note is that if we have a data point here and a data point here, these might come from the same individual. In fact, if they come from the same individual, you can think of them as related. This data point here tells us something about this next one because they came from the same individual. So the way we capture that, and again, because individuals often have different characteristics, relevant features that aren't represented in the data, they're not measured. There may be there's parts of the biology of different diseases where we don't understand all the different underlying features. It's something that's kind of effectively seems random, where some patients may have a different intercept, and this is something we call a random intercept. So we can and a random effect. So each patient we can allow to have a different intercept or even a different slope, or put the two together in something like over here. And this is true not just of patients, but we can also look at this for different studies. Switch back to the laser pointer. So this is a very really important thing we can do here, where we can actually allow each individual to have slightly different intercepts or slopes, or slightly different disease trajectories. And we can account for that even with things that we don't fully have measured in random effects. It's not accounted for in the same way we would with like something age, where we're looking at different patient populations, but it's helping us get a better estimate of the population as a whole by accounting for the fact that these are related values. And again, this might be a little bit vague, but I just want the take-home message here is really just we can capture kind of the random intersubject, interstudy variability using these models and get a better sense of what the variation in the population is. Okay. So here I have a schematic where I'm just trying to summarize what I've been talking about. So these disease progression models, they take as input all these different, patient characteristics, biomarkers, treatment regimens, other information, and we put them into some kind of statistical model, usually some kind of mixed effects model. So it includes those random effects. We can account for the intersubject or the interstudy variability, and then we get an output, which is the expected population time course. So, and that's that can be for the population as a whole or different subpopulations based off of what we've actually put into the model. Okay. So that hopefully was not too much for the basic idea of what the disease progression models are, trying not to get too much into the statistics, but give you a basic idea of how they're supposed to work. So let's move from here into how they're used. And I have two ways that they're used highlighted here. And I think these are kind of two of the main ways, but it's not necessarily supposed to be complete list. They can help us with our knowledge of different things. They can help deepen our understanding of the disease in some way. But I think the really key one that I want to focus on today is prediction. We can use them to predict what's going to happen with a typical patient with certain characteristics. We can get an estimate of their time course of what their disease looks like over time and the expected variation in different populations. And this is really important for drug development. So, I think so. Before I get here, I just want to say just a note on this. There's a number of uses for these disease progression models, but the one I want to focus on that I think is really important is how they get used in drug development. So let's talk about that. So two major challenges with drug development are just trying to understand how big do you make a trial and how long do you run it. So if you have a trial that's too small, you may have a difference between two populations. It might be real, but if you don't have enough patients, what happens is these error bars around your estimate, around your, maybe not even estimate, this could be your measured like mean for each group. These error bars are overlapping, which tells us that statistically, we can't actually say these are different groups. Whereas if we have a ton of patients, let's say 10,000, we can see a very clear difference. However, running a trial where you have 10,000 patients in each group is very expensive. So we want to not use quite so many. We want to use enough, but not too many where it's too costly. And one of the nice things about the disease progression models, because we've modeled kind of the whole trajectory, we have a sense of the variation in the population, we can actually get much better estimates. So like using a model, it might tell us, for example, that we only need 100 patients rather than the full 10,000. Okay. And then something else that's very important is they can give us information how long to run a trial. I think that's just best thought of visually here. So if we look at this simulation, using a disease progression model of this MDSU-PDRS part 3, we can actually see that over time, if we were to run a 12-month trial, you can actually see that these two groups, so the solid lines here are the medians of each group, and then these bands are kind of, they're giving us a sense of the error of how much variation there is in these different groups. And we can see that at 12 months, these are overlapping. These may not give us a good sense of whether these two groups are, this is suggesting to us that this may not be long enough. We might need to run the trial for longer, a few more months later, before we expect to see an actual difference between the two groups. And then another major challenge in drug development is enrichment. How do we know who to include in a trial? So this is a figure from a paper from 2010 looking at deaths from prostate cancer on this y-axis over years. And one thing that's notable here is these are different biomarkers. This is a biomarker of your risk of death from prostate cancer, which is called PSA velocity. And the important thing to note here is that if we were to enrich on the wrong patient population, by that I mean selecting for the patients to include in the trial. So which patients we include, if we include a bunch of patients who, let's say, have less than 2 nanograms per milliliter per year, we might not expect to see many deaths at all. In fact, there may not be enough deaths to discern between a treatment group and a control group. Whereas if we were to enrich and select patients with PSA velocity greater than 2, now we're actually seeing a number of deaths, and maybe we can actually see a difference between groups. So depending on who you enrich for in the trial, that can affect what the outcome looks like. And because disease progression models can take these kind of information into the model and look at how those trajectories change, we can actually see, when we pick this particular population with this particular biomarker, we can see what their trajectory looks like. And here's another example. This is just noting that diseases do not progress at the same rate for all individuals. So this is a paper in polycystic kidney disease from 2015, looking at what's called Mayo classes. And these different classes take here's the height adjusted total kidney volume. So for those of you who aren't familiar with polycystic kidney disease, it's when the kidney starts growing cysts, or cysts start growing within the kidney, and the kidney slowly grows in size until it reaches a point where it can't function anymore. And this happens over patients' ages. And what we can kind of see is that these different classes have grouped patients in these different classes. So this is kind of like a biomarker of the rate of disease progression. So if you were to run a trial and you select patients in class A, you might have to run that trial for an extremely long period of time before you see any notable disease progression, or any notable reductions in disease progression from a drug. Whereas if you were to enrich, say, on class 1E or 1D, then you'd be able to more likely see the changes in time. Okay. So just to kind of summarize here, so of these challenges, we want to understand the patient differences, and these can inform things like trial size, duration, and who to enrich on. So let's look at an example of this. So I showed you this. Oh no, sorry. This is a new plot. This is a simulation looking at Alzheimer's disease. This is the CDR-SB. Let me just remind myself what this means. This is let's see here. I don't want to say it incorrectly. Okay, clinical dementia rating scale. So when we're looking at this over time, we can kind of see here, we can design a trial. Let's say we have 500 subjects in each arm. We have a certain assessment interval. So we're planning to do assessment intervals every month, and we're running this for 24 months. And then we want to, we have a certain drug effect we're expecting. And we can use a model, this model in this median CDR-SB, to kind of see what those trajectories would look like. So if we have 500 patients with this kind of drug effect, and we were to plot this out over time, we can actually see these different patient populations. And also importantly, we can look at the different patient characteristics. So here we've got about half male, half female population. We have, and different biomarkers. So ApoE4, et cetera. So we've enriched for different biomarkers. We have certain patient characteristics, and we're able to plot out the whole course of disease trajectory. And this is particularly useful in this case because not only are we able to identify the patients who are, because we've included in the model these different biomarkers, it's kind of who we want to look at, we can also get a sense of how long we need to run this trial. So in this simulation, we might only need to run this particular trial for 12 months, because by the time you get out, because this is all it takes to start seeing the difference in groups. So these models are useful. I hope this is giving at least a sense of how these models might be useful, because they give us all this information, which can be turned into a more informed planning for clinical trials. And I want to take it a step further. So sticking with this example, we can actually add in more stuff and further update these models. So let's say we have a situation like we saw in COVID, where there was a lot of patients who couldn't make it into a clinic. And so they were effectively, dropping out of this trial because they weren't able to make it into the visits anymore. And we can kind of plot out over time how that changes the trajectory. So you might see here, early on, we've got relatively tight error bars just kind of going up. They're getting wider over time. And we're also seeing that, we have patients who aren't able to make it into the clinic. Maybe they're not able to always get the drug treatment in the regular intervals. We can kind of see that these groups are not differentiating over time. So we can take this into account, and we can see what happens to the trial in terms of the simulation, right? So we can get an expected look at, what happens over time. And we can even go further. So let's say that we do have, same situation. We have, like with the pandemic, we have COVID, it's preventing patients coming into the clinic, but now we allow, instead of, they just have missed visits, we now allow for virtual visits. And what we've done here is we've added in some extra noise. So with these virtual visits, because it's in a environment which is not controlled. So in the clinic, everyone's going to the same place. They're getting the same assessment. Here, things are happening virtually. So the actual patient's, living area or the situation they're in where they're getting the assessment can vary a lot more. So we add in a little extra noise, and then we kind of relook at the trial and what happens. And we can actually update our information in these kind of models. So this allows for very sophisticated trial planning, where we're able to account for a lot of different things in the trial, not just in terms of the disease biology, but also in terms of the environment, in terms of what could go wrong. Okay. And then there's one other topic. I'm not going to spend very long on this. This is a topic which is important. I think it doesn't get discussed enough, so I want to mention it. It's that these disease progression models can also help us with communication. Oftentimes, these diseases, they have a lot of different features. They can be very complicated. Being able to put all this together into a single model that people can look at and use to make these kind of simulations helps kind of have conversations about the model and about a trial, because you can put different things into the model. You can simulate a trial. You can say, okay, this is what happens when we do this, or this is what's expected to happen when we do this. Not necessarily what will happen, but what's expected, what's predicted from the model. And just to give an example, again, I'm not going to go into all the details here, but these models can give us a lot of information, and they can allow us to do a lot of different things, like changing duration of the follow-up, the assessment interval, the number of patients with these different biomarkers, et cetera. And they can be this turns into a different output, which again, these different inputs and outputs can be used between sponsors and regulators when conversing about, how to plan a trial. So this helps with communicating about these different trials and helps with drug development in that way as well. Okay. So that's kind of the main thing I wanted to focus on how these disease progression models are useful, is that they can be useful for drug development. So just a bit of a summary here. These models help inform variability and expected disease course. They allow for accurate estimation of requisite trial size and duration, assuming you have the model specified correctly. Obviously, if you have an incorrect model, it's not going to give you accurate estimates, but assuming you manage to get that, these can be very informative. And they incorporate various patient characteristics, biomarkers, relevant features, which allows us to enrich on different things, look at different populations, ask, what is the patient with these features or with these biomarkers? What does their typical trajectory look like, and how much error do we expect to see? And then they can be, again, I haven't talked too much about this, but they can be turned into something that is more user-friendly. So like some kind of GUI that is doing a simulation of a trial, which is helpful for informing planning conversations, because you can actually use this GUI, input the different inputs, see what the expected output looks like, what the predictions look like, and use that as a way to kind of inform your trial planning. Okay, so moving into the last part of the talk here, I want to also spend some time thinking about how these are useful in the context of rare disease. And I think one thing that's really important to note is that everything I've been talking about thus far is still relevant to rare disease, but there's a couple of challenges that crop up more often in rare diseases. And the 2 bullet points I have here is, I think, obviously not meant to be a comprehensive list. These are just the 2 things I picked out that I wanted to focus on today. And one of them is just the most obvious, I think, which is that with rare diseases, you often have limited patient populations, which creates additional challenges in studying the disease because you have less patients to look at. So it's harder to know whether you have patients that are really representative, or whether those patients you're looking at are actually unique and don't represent the typical disease course as well. And this also makes it challenging to validate promising treatments, because, as I mentioned earlier, if you have fewer patients, it can be harder to get a statistically significant effect at the end. And this also creates, there's also challenges around choosing endpoints. So this is something which I think is true in any disease, but maybe exacerbated a little bit by having a limited patient population, where sometimes you have endpoints which they're useful for looking at the severity of the disease, but they might have a lot of variability. So for example, if we're looking at different disease scores, like we look at for some of the neurological diseases, where we have a clinician and a patient who's trying to evaluate how well the patient is doing a task, there can be a little bit of subjectivity in terms of how well the clinician thinks that the patient is doing, and also a little bit of, sometimes the patient's just having a good or a bad day. So that creates a little extra variability in that endpoint, and you would need a larger population to see a significant effect. So disease progression models will not solve these problems, but they might help alleviate them in a few ways. So they have potential to, because we can kind of synthesize a lot of patient and a lot of study data together, they can kind of help deal with the fact that we don't have as much information and kind of make the most out of sparse data. Okay. All right, so I want to just give a couple of examples here. So this is an example from kidney transplant recipients. So, chronic kidney disease is relatively common, but the number of patients who get kidney transplants is not very many. So we're often working with quite limited populations in kidney transplant. So what I did here was, and this is not just me, this is obviously a bunch of co-authors, a paper we published in 2023. So I obviously did not do this alone. Everyone here contributed quite a lot. I would not have been able to do it without them. And I just wanted to kind of explain what we did. So one of the challenges in kidney transplant is that there's this early wake-up phase. So after a kidney is transplanted into somebody, it doesn't immediately start working all the time. Sometimes it takes a little while for it to, I guess you could say, wake up. And sometimes that wake-up phase is delayed. We call that delayed graft function, because it takes longer for that patient's kidney that was transplanted to start working. And it takes longer for that patient to get off of dialysis. And this is important because it's related to long-term graft survival. There's been a number of studies showing that if you have a delayed graft function, this affects your chances of having a graft failure further on down the line. So what we did here is we built this nonlinear mixed model looking at estimated glomerular filtration rate. So this is one of the most important biomarkers of kidney function. It's really estimating how well the kidneys are filtering, kind of doing their main job. And we limit it just to kidney transplant patients. And as I said, ordinarily, this early wake-up phase has a lot of variability, so it's very difficult to model. But because I was able to combine a lot of different data sets together in a single disease progression model that allowed for a different trajectory here, I was able to get robust estimates. And this is the kind of an example of a model predicted trajectory. I've set some parameters so you can kind of see this difference in the early phase and the later phase more clearly. You can kind of see that you have this really early. Most patients the kidney gains function very quickly, just over a few days. It goes from 0 up to quite a bit more, at least by the model trajectory. And then they'll lose a little function and then stabilize. And that's, some patients don't lose function, they just stabilize up here, but this is just an example of what a trajectory could look like. And then I'm showing you this plot over here, which is called a visual predictive check. I don't want to get too much into the details of what this is. I just want to kind of give you the high level overview of the take-home message here. So what this is doing is it's looking at all the data we had for the model. So these are gray circles, and we have the eGFR on the y-axis and the time on the x, and we're looking at a number of things. But what I really want to focus on here is this median, is this solid black line and this red colored band. So this solid black line is the median we see in the data. So if we look at all of our data over time, this is what the median looks like. And there's patients who are losing their graphs, so they're not continuing on. So we're kind of seeing this very slow decline. Whereas in reality, each patient, we'd probably expect to see a little bit faster decline than this. So there's a little bit of survivor effect. But the important point is that the model is capturing this trajectory at the mid-range. And this mid-range is extremely important. And so what this red band represents is that the model, if we were to take that model and simulate data using it, the median of that simulated data is matching the median of the actual observed data, even at this very early range, which is where there's a lot of variability and it's harder to measure. Okay, so by taking all those data sets together, we can actually get an estimate of the we can get a more robust estimate of how this is working, and we can get an estimate of this wake up phase, and we can use that based on the patient characteristics to kind of predict, is this patient more likely to have that delayed graft function, which we can do other ways as well, but this actually lets us model it. Okay. And then I want to talk about one more example, and this will be my last example before finishing up here. And this is a really challenging question, I think. This is true in rare disease and it's true outside of rare disease. And it's which endpoint do we use? And in some diseases, so like in kidney transplant, it's, I think, clearer because we can estimated glomerular filtration rate is such a good estimate of kidney function. But in something like Huntington's disease, getting a great estimate of something that's happening neurologically, it's more challenging. What we have are these different disease scores. So this TMS is a total motor score, SDMT is single digit modalities test. And this is a table taken from a very recent paper from Jeff Long and his co-authors in 2023. And one of the things that's really, I think, key and important when we think about these endpoints is we're not just thinking about how well they capture the disease severity. We're also looking at the variability within these endpoints. And one thing I just want to highlight that struck me when I was looking at this table is we see these mean values, but like for TMS, and then the standard deviations are almost as big as this mean value, sometimes bigger. And what that highlights is that when we have an endpoint that has a lot of variability, we often need more data to kind of see significant differences. So these endpoints aren't chosen from the model. So the model doesn't actually help us like choose endpoints. The endpoints are based on something upstream. It's really scientific clinical research and knowledge. However, they do help us think about how well these endpoints are going to work. So if we have enough data, we can actually kind of look at these different endpoints in these models and simulate these trials and say, well, in this trial with this patient population, we get a sense of how well this particular endpoint is going to work. So again, it doesn't help us necessarily with the availability of the different endpoints we can use. But given that we have some endpoints that we could choose from, we can look at them, use the modeling to help us kind of pick between them. Okay, and I think that's about it, and we're about out of time for the discussion part. Some conclusions. I'm going to skip through this just because I think we're starting to run low on time. And oh, wait, sorry, I skipped a slide. Okay, so no, I'm going to run through the conclusions really quickly. So these disease progression models synthesize the knowledge of disease biology with sophisticated statistical techniques to help plot the time course of disease progression in different populations. And they help us meet the challenges in rare disease and in the way that synthesize data sets. And again, we can't really solve, these are major challenges that are solving them is beyond, I think, any one technique, but they can help us deal with them. And then we can put them into these different tools that help us kind of user-friendly interfaces that help us see these models and plan trials, and that give us information about how best to plan a trial. Okay, and that's it for me. I'm going to pass the slides back to someone else to control, and happy to move on to the Q&A panel. Thank you all for your attention.
Thanks so much, Luke, for a very compelling presentation. So we're going through a Q&A right now. So we have a little, as a reminder, we have a little Q&A chat box for our audience to type in questions. We have a few that we're going to start addressing. Joining us for this Q&A, it's my pleasure to introduce you to Francisco Morales, quantitative medicine scientist for CPATH, and Diane Cui, senior quantitative medicine developer. Please welcome them to this Q&A session. Just look to let you a little time to get back on track and take a look at the questions. Just some overall comments on the presentation. I think you said something about making the most out of sparse data, and to me that really triggers something else, and it's a shameless plug to my program, the RDCA DAP, where we really provide a platform to get the sparse data that is potentially out there and centralize it. And so there's an important part of that work is that you need data. And, on my end, I'm trying for rare disease to bring a place and to try to get people to share data to the platform so we can centralize that sparse data and maybe increasing the amount of information available that your team can then leverage to develop all these efforts. I think another thing that I find really important, and some of the things that you should really highlight, that is that when we have these discussions on the unmet needs with rare disease communities, there is a lot of hope that we're going to create an historical control, a synthetic control, so that the kids don't go on placebos. We're also going to have hope that we're going to get to the trial simulation tool and these apps and stratification apps that we can generate. I think the work that you are doing is also, it's important to highlight that it's paved with discovery, that you take a deep dive in the data and you create knowledge. And so we have these big hopes and we're going to work toward that as much as we can. But along the way, it's paid with discovery, it's paid with knowledge. And that's very important because it is also helping. So I just wanted to highlight that. If you want to comment, feel free to comment. And then I will let the professionals and all the technical questions. And Francisco, I know I already found a few questions to start with.
Yep, thank you so much for that. Yes, that's a very good point. This is there's a major, I guess, ethical concern with putting anyone on a placebo especially when you have advanced progressive disease, because the longer they're on placebo, the more their disease is progressing, and that's a major challenge. There's a lot of promise, I think, with real-world data. This is something which I didn't cover specifically because it's broader than just disease progression models, I think, as to the usefulness of it. And it's something which it's very tricky because you have to make sure you're matching your patients in your trial to whatever you have in the real-world data or to simulated data. But it can give you these models can kind of give us a sense of, if we were to match properly and limit it that way, we can start looking at what these models would look like. I think one other thing we can note is there's other, I guess, sophisticated trial design techniques we could use that might allow us to, there have been some techniques developed for how do you discern a treatment effect when you're allowing patients to switch off of the placebo? So there have been some trials that were done in the past called randomized delayed start trials, where it was actually built into the trial where you allowed patients after a particular period to switch to the treatment. And the design of this trial was to kind of figure out whether there's a real underlying effect that's affecting the disease progression rather than just the symptoms. Because if you switch everyone from the placebo onto the treatment, and if you've only changed the symptoms, that treatment group should, in theory, at least catch up to the treatment, to the earlier start group. And there's the other techniques which try to account for the fact that if you were to take a patient who is, let's say they've crossed some threshold of disease severity, you want to make sure they're getting some kind of treatment, you switch them to treatment, how do you estimate at the end of the trial, what's the difference between the groups after you've allowed patients to switch? But I didn't cover that specifically in this talk because that gets a little outside the scope of disease progression models specifically. So I think you're making a very valid point. It's a major challenge, and it's obviously a question that's relevant to disease progression models that they can be used for. But I think the question of real world data is actually much broader than just disease progression models. It's a question of how do we really take the patient subset that fits with the data, the patients we really want to look at. So if we have a new patient group that we want to test a drug in, and we have, say, historical data, then we can, try to, once we've matched that, we can put that into a model. But that matching is something that's, I think, that happens upstream of the actual model itself. And then I think you made a point about simulated data. This is something that I'm not sure I am qualified to comment on. These models can definitely simulate data, but actually using like a simulated or like a, I guess like a digital twin. This is, I think, a little more of a regulatory science question, if that makes sense.
Yeah, I wasn't getting there, but that's still a relevant comment. Francisco, I know we have a lot of questions, so if you want to start.
Yeah, sure. Thank you, Luke, for your presentation. And we have some questions from the audience, which I think are very good and very insightful. One question from Scott Milligan. He asked if you could speak on how whether this has been used for existing retrospective data, more specifically for real world data, where he comment like timing and completeness of data is highly variable. Do you have any comment on that?
Yeah, so I think this is, I guess, what we call real world data. So if we go to the example I gave of the EGFR model that was built for kidney transplant patients, some of that data was not brand new. It had been in studies that had been done a little while ago. So it was using, I guess you could call, retrospective data in a lot of places, but that data is still very relevant because how should I put this? The way we treat kidney transplant patients hasn't changed too much over time. It's changed a little bit to switch from cyclosporin to tacrolimus, which is some of the drugs that have been used. But a lot of that data is still very relevant in terms of how the disease is progressing, the rates of kidney rejection. So as long as the data is matched properly, like is still relevant to today, yeah, there are definitely examples of using more historical data. And we also had more data than we could actually put into the model because some of the data, as I think was mentioned in the question, is incomplete. So when we're missing too much data, sometimes we can't use it. But as long as we have enough of it, we can still use it for modeling.
All right. Thank you very much. Another question that we have from Shenifem Farmer, sorry. Actually, a few questions. The first one is like, what do you do when you don't have continuous measure over the disease curves?
So that's an interesting question. So a lot of these measurements are continuous, but not necessarily. So for example, in Huntington's disease, total functional capacity has basically 13 categories, or actually I think it's technically 14 because its max is 13. I think 0 is also counted as a category. And you can also split that up into different groupings. So you could model it not as a continuous endpoint, but as a categorical one. And this is a different, it's a different type of regression model, but you can still measure that. You can still use that as an endpoint. It doesn't have to be continuous.
Great, thank you. Also, another question that she provided is like the challenges. She commented actually, like some of the rare inherited diseases is that they are usually or pretty often multisystemic like diseases. And you have, for example, in some cases that the genetic mutation is the one that provides like the variability. And but the idea, like the question basically is like, how to account like how multiple system affects or influence the disease progression models.
Right. So these, I think this is kind of hits on the point that these are often complicated diseases. They have a lot of different features that contribute to the disease. I think Huntington's disease is, I keep coming back to this because it's one of the diseases I've worked on, but I think it's a good example of this, where we have, for example, a major genetic component, the number of CAG repeats affects the disease progression. More CAG repeats, the faster the disease is expected to progress. And this is just one aspect that can go into a model. So these models have a lot of different parameters. The one I showed, the very simple one I showed previously, was just an intercept and slope. But if we were thinking about this, that CAG repeats would be affecting the slope. So it's a kind of a covariate, we call it, we'd add to the slope, and that affects that slope with depending on what the number of CAG repeats. And these different aspects of the biology of the disease would go into different parts of the model. So if we have something which we only expect to affect that intercept versus something we actually expect to affect the rate of progression, and it doesn't have to just be one thing. We can add on multiple things. So like we can think of CAG repeats, but maybe if we had another biomarker that is also indicating like how fast disease is progressing, we could put those two together. We can even think about how they interact. So yeah, it can get very complicated in terms of how we actually put all these models together and how we take all these different pieces of the disease and put it into a model in a way that is relevant.
And look, in Francisco, we have some. Thank you for that. We have some kind of related question on the data and the amount of data that I touched upon. And a comment from Gilbert L'Italien, that person who works in spinal cerebral ataxia, where they know the progression rate varied by genotype. And so there are evidences in one of the subtypes of spinal cerebral ataxia that tied to that genotype, there's a longer trajectory, but they're lacking numbers for other subtypes. And, is there anything we can do now, or do we need to wait for more data and that's the only thing we can do at this point? Do you have methods that can kind of help you make some predictions? If you have some data, but maybe it's not as much as you want to, but is there something you can start doing? And I think there's, on a related note, there's a question about the amount of data that we need to get some of the work you're doing. Potentially there is a path for regulatory endorsement of a trial simulation tool. What do the regulators say about the amount of data that you need when you build a tool for rare disease, and you may have 2-3 clinical trials that are sufficient to start really building the tool? If you can comment on that aspect as well of overall data amount and lack of data. And Francisco, feel free to add on if you want.
Yeah, so I'm going to I'll make a brief point and then I'll pass it over to Francisco. I think I mentioned that, these models can help us with some of the problems we run into, but they won't necessarily solve them. So sometimes it is true, you just don't have enough data. Even with the model, you try to fit the model, you just can't get robust parameter estimates. Basically, the more data you have, these parameter estimates, the error in them will shrink. So if you have too few data, you can reach a point where your estimates of these parameters, you can't get a good estimate, basically. So there's definitely situations we run into where sometimes we don't have enough data. And I think the strength of these models is the way they let us put, different data sets, kind of put data together as long as we can say it's still relevant. And kind of deal with the fact that we may have a bunch of different studies that each have sparse data, but when we were able to put them together, we can get more robust estimates. But they don't necessarily solve the data problem. If we don't have enough data, sometimes we just don't have enough data. And that's when we get back to the regulatory question, you know, the regulatory grade science, it needs to be pretty well tested. And sometimes you can show that we just don't have enough data. And then I don't want to speak for any regulators, but you know, that I expect to have more regulatory scrutiny. And then just a shout out to a different approach. The stuff I talked about today was really focused on kind of a frequentist perspective, but there's Bayesian perspectives as well. And Bayesian methods will have priors. And the stronger your prior, oftentimes the less data you need. So I'm not a Bayesian expert by any means. I don't think I can really comment on the usefulness of Bayesian methods here, but they at least have potential to deal with sometimes very sparse data and still get robust estimates, but you have to put that more of the work of the model into that prior. So yeah, let me pass it over to Francisco, because I know you've also worked in ataxias.
Yeah, well, basically, I would like to echo a little bit of what Luke said, related with sometimes the lack of data it could be an issue, even though with this modeling technique that we use, the modeling, the mixed effects, you could combine different data sets, for example, natural history data or clinical trial data from placebo arms, and you could like combine them and simulate or create the models trying to capture the trajectory of the disease progression. However, that could it could be a solution, but if there is lack of data, there is lack of data. And unfortunately, any model is based on how good the data it is. So if you are not able to combine and have a robust data set, it will be very complicated to create a robust model. I will keep going with the questions. Actually, one question from Enrique Ivan Rodriguez Garcia. I think also actually it's kind of related with what we were talking about. Like his question is like, any thought about how to apply disease progression models in glomerular disease research? I think it's basically related to what we were talking about, which is depends on data. If you think that there is data available, I think it could be something that would be possible to do. However, I'm not very familiar with that disease, but if you think that there is like a disease progression data available, I think it could be potentially possible.
Yeah, I don't think I have anything to add to that. Francisco covered it.
Thank you. I think we have another question. Someone asking us to elaborate, asking you to elaborate on the possibility to simulate multiple endpoints at the same time. For example, primary, secondary, with
Right.
the type of modeling work you do.
Right. And so this is one of those things where I think whenever we come to there's a lot of questions where I think the answer is kind of, it depends on, you know, what you're doing, what you want to do. But there is a type of model which is used in disease progression modeling called a joint model, where you have more than one endpoint. And I actually think I'm going to pass this to Francisco and Zihan, because I know you've also worked on this. But you can look at more endpoints. You can look at endpoints simultaneously. So.
Yes, actually there are several examples, or at least that I know, where you can have different endpoints in the same model. One is actually for Duchenne muscular dystrophy, where recently actually was published that you could model and have several endpoints, but anyways, they're in the same model because also one affects the other. So you're able to do that again because data was available for multiple individuals and that was feasible. Another one that I am aware of is related with type 1 diabetes, which is the one that kind of Luke mentioned, is a joint model where the glucose levels are correlated or are in conjunction with type 1 diabetes diagnosis. That's another example of one type of model. Again, this is progression model where you have multiple endpoints for it.
All right, thank you so much. I think we're going to go through a final question. Oh, you have a comment, Luke? Go
One
ahead.
question. I think I saw Zihan on mute, so I just want to give Zihan a chance to add anything if you'd like.
Yeah, just another example maybe for polycystic kidney disease. We have multiple endpoints predict. In that example, we even use one of the endpoint to predict another. So yeah, just add one more example. Thanks.
Thank you. So maybe a final question from Kara, who works for Iridia, a partner with RDC ADAP. Many progression models and simulators are built on with the classical trial design in mind. How could they still add value to other adaptive trial designs, especially when an adaptive trial can be beneficial for small patient population or aggressive progression like we see in many rare diseases?
Right. So let's see. So one of the things that I've worked on is this. It was a model-informed drug development broad agency agreement for the FDA, where we were looking at basically taking models that were previously developed, mostly models that were previously developed for like Alzheimer's and other diseases, Duchenne's, for example, and taking the kind of clinical trial simulators that have been built using these models and adding on adaptive trial design modules. So adding on response adaptive randomization. I could ask Zihan actually to say a few words about that, as well as some others. So looking at, for example, adding on like a platform trial module. So we're looking at, it's still the same disease model, but now we have an additional challenge where we're looking at multiple treatment arms at once. And we also have an additional challenge there where we're actually, because we're comparing more than one group to another with multiple comparisons that we have to account for. So these models, they're looking at kind of an overall trajectory, natural history, and a lot of these tools that are built with the classical trial in mind, but the model themselves can be more flexible. Like if you are looking at multiple, like in a platform trial, if you're looking at multiple treatments, you could simulate multiple drug effects and compare it to a single control group. You can still do that without even changing the model. So I don't know, Zihan, if you'd like to add anything.
No, I think your explanation is quite good. And we just add some more modules based on the existing disease progression model and to build up a new web app.
All right, thank you so much. Yeah, just very quickly, like a final one. We had a comment from Michael Liebman mentioning to us that the way he used the progression model is a little different. It doesn't use it for clinical trials, but to stratify the disease into clinical subtypes to get a better target selection for disease subtype early in the discovery process. So just wanted to bring that comment here on another application to our audience. If you have any comment.
Yeah, the only comment I have is, as I said, the uses of disease progression models. I didn't intend this to be like a comprehensive. They're really just used for clinical trial design. That's the main use that I wanted to focus on because that's kind of what I have the most experience with. But absolutely, there's other uses that you could use them for.
All right,
it can be very flexible. Yeah.
Great. With that said, thank you so much again for your great presentation and for these panel discussions.
Thank you for having me.
To reiterate, if there are any questions we haven't addressed, we'll reply to you by email. And this webinar will be available on YouTube in the next few days. We have an upcoming webinar for under the rare and orphan disease webinar series. The next one is really focused on the partner of RDC ADAP with a webinar from the tuberous sclerosis foundation that is the Tuberous Sclerosis Alliance, a rare epilepsy disease, who is an early partner of RDC ADAP and share data to us very early in the program. And so they're going to come to this webinar. Elizabeth Cassidy will present a webinar on improving data collections for rare epilepsies with a case example from their natural history study. And so looking forward to have a lot of you join again for our next webinar, which will be on March 14th at noon Eastern. Thanks, everyone, and see you in a few weeks.